Yeah, and good evening, everybody. Today we are going to deal with pediatric palliative care, and we have two Indian faculties. And actually, in India, we don't have much people who practice pediatric palliative care. So we are lucky to have Dr. Spandana and Dr. Prasad here. So Dr. Spandana, she's a pediatrician. And she also did a fellowship in pediatric palliative care from MNJ Institute of Cancer Care, Hyderabad. And then she worked as a pediatric palliative care consultant in two World Cancer Association, MNJ Cancer Institute, Field Relief and Palliative Care Society, Hyderabad. I think for almost 6-7 years, or more than that. And then she shifted to Kuwait, and now she is the pediatric palliative care specialist at the Beit Abdullah Hospital in Kuwait. And she has a lot of experience in pediatric palliative care and also in teaching. And she has been faculty for various training programs, not only in India, but also in other parts of the world. And a good friend of mine. So welcome, Spandana. And next, we have another person who is also a very good friend of mine, and Dr. Prasad, who is the professor of palliative, professor of pediatrics at Government Medical College Hospital, Palmacheri. And he has been instrumental in starting pediatric palliative care at Sri Autandarnath Hospital, Trivandrum, which is the pediatric department of Medical College Hospital, Trivandrum. And he has been actively working with pediatric palliative care. And even now, he is working for pediatric palliative care and has been a faculty for various training programs for pediatric palliative care. So both of our faculties are very much experienced in pediatric palliative care, and Dr. Spandana will be speaking on the differences between adult and pediatric palliative care, or how pediatric palliative care is different from adult palliative care. And Dr. Prasad will be speaking on neurological part of pediatric palliative care. So I think first Spandana will be presenting, and then Dr. Prasad. So Spandana, it's over to you.
Thank you, Dr. Sunil. Hello, everyone. Very nice to see you all. Good evening. Congratulations on joining the Global Fellowship in Palliative Care, and you have joined with a very eminent institution. So congratulations, everybody. And you have Dr. Sunil overseeing the program, and you all know how efficient he is and his team is. So great to see you all this evening. As he said, I'm Dr. Spandana. My background is pediatrics. I will keep talking because a lot of times my presentation doesn't get shared on the first attempt. Just let me know if you see the slides now. Do you see them?
Visible.
Oh, wow. That is a first. Anyway, I'm usually very, very curious. I'm just trying to see how do I make it into slide mode, because this is not moving the lower buttons part of it. Okay, now it did. As he said, there are very few of us, and then working in different settings, we get very curious about how palliative care is in different places, and also about how palliative care is different between adult and pediatrics. As we dive into the slides, if possible, try and be as interactive as possible. We have, I think, around 40 to 45 minutes to cover ground. And I would really appreciate if you're able to unmute and speak. Do not hesitate. Right. The next slide. why do we even have to discuss the differences between adult and palliative care? You're doing a fellowship in adult palliative care. You might just as well see adult palliative care, spend all your time on adult palliative care. Why are you giving 2 hours of your valuable time to discuss this?
Dr. Spandana, extremely sorry to interrupt. I thought you said the next slide, but the slide was not moving. In the first
Yeah, I know this happens every time. I don't know if it's
no
a
worries.
problem.
It's completely
Yeah.
okay. Happens with almost all.
Can you see it now? Like the second,
Yes,
are they
I can
moving the
see it.
slides now?
No, the slideshow has not been put up yet. So,
okay, let me try again. But in the meanwhile, I would like to ask the participants, why do we give 2 hours of our time for discussing this? Dr. Ashok, you are unmuted, I think. Do you want to say something?
Yeah, it is a pediatric palliative care is a specialty by itself. Unlike the adult palliative care, where the pain treatment and all are a little different from the adult when you are going into pediatric care. That's why I think we have to discuss this and to understand how you treat pediatric case in a palliative care setting.
Thank you for saying that. I agree. I wouldn't say it's so. I would say adult palliative care is actually recognized as a specialty. Now we do have MD palliative medicine, DME palliative medicine, whereas pediatrics is still in the subspecialty phases. But as you said, there are definitely a lot of differences. And then when you're seeing adult palliative care and when you're saying holistic care, a lot of times there are these children in the background, grandchildren, children of our patients, niece and nephew of our patients who are forgotten because all our concentration is trying to treat our patient, adult patient, and these children are forgotten. That is one part of it. So sometimes just thinking about children's palliative care, even if you do not practice pediatric palliative care in the future, you are going to see children in adult palliative care, and you will be able to see them because a lot of the times we don't see them as healthcare professionals. The other part of it is, sorry. Yes, I can see that. Yes, thank you. The other part of it is that also, yes, it is most neglected because a lot of times we are all talking about cure and we don't talk more about palliative care in itself. So next slide, please. And if you're all going to go practice in communities, you're all going to see children, mainly those with neurological disabilities. That is why Dr. Hari Prasad is going to speak after us and describe in detail about neurological problems that we are going to see. But there is no one else to step up for these children. And if you are those adult palliative care patients, you will end up seeing pediatric palliative care. And I'm sure Pallium India wants you to be equipped to deal with these children and help these children. I see as we are dealing with children, child, we have to give more attention like we treat normal children, probably more than that, right? Going forward in the presentation, let's discuss the similarities between adult and pediatric palliative care. Next slide, please. Yes. So just like adult, the diagnosis itself, at the beginning of the illness, you can say this needs palliative care. So in children, if they're diagnosed with leukemia, it doesn't have to be, let me wait till the leukemia treatment fails or, there is a relapse. You can start at the time of diagnosis. Or if you diagnose them with advanced AIDS, you could start it at that point itself. So it doesn't have to be something that is end of life. Again, it's quality of life. As always, we are concentrating on that. Then again, in pediatrics, we do have to make help in decision making and also setting out goals of care for each child. And then we are involving various disciplines. It's always interdisciplinary and sometimes multidisciplinary teamwork, especially when it comes to pediatric palliative care. Next slide, please. So what are the differences? lot of times, especially when we go into communities, you see that children are treated as mini adults. Anything that you do for adults, half it or quarter it, and that's what we give for children. But that is not how it works when it actually comes to practice. There are quite a lot of differences, and you will see that as we go forward. Next slide, please, Priya. So can you think of any differences in the, I agree, Jagrati, we will get into that. So can you think of differences in palliative care diagnosis in itself? What are the most common diagnoses seen in adults? This you have to be able to say.
Like end organ failures and all that.
Yes, end organ failures.
Chronic
Parul, go ahead, sorry.
Most in adults, we see chronic non-cancer patients, whereas in children, there are all maximum majority of the times it's malignancies or cancer cases.
Very interesting. Let us go into further slides. I like that you said in children, it's majority cancer. Next slide, please, Priya. Okay, this is from the Global Atlas of Palliative Care 2020. Also see the N number, right? It is a big number. And then if you look at it, even in adults, we are giving around 30% for malignancies, 20% change for HIV, 12% for dementia, and rest of the things, there are some, right? Next slide, Priya. Okay, the N number goes down because children are lesser. But if you look at malignancies, leukemia plus malignant neoplasm, so just 5%. Right? In pediatrics, it's not cancer in itself, but because we are all established in, Parul, thank you for bringing this up, right? Because a lot of times this is the, I wouldn't say a mistake, but this is a misconception all of us have regarding children's palliative care, because we are based in cancer hospitals mostly, that it is cancer that needs it. But if you look at it on the top, it is 17.7 and 16.2, which comes up to close to 40% of premature birth and congenital malformation. So if you want to do pediatric palliative care, I think you will have to dabble in neonatal and infancy stage itself, less than 1 year a lot of times. And then HIV is close to 30%, which would be surprising to a lot of us. I think these numbers are more skewed because it's a global picture, and this would include the whole of Africa. And that is why you would see HIV here. But then there are some end organ failures, renal diseases, and syndromatic children, and all of them. So why I'm saying this so specifically is that let us not always think that it is cancer that we are helping, cancer children with cancer that we are helping. But there is so much more we can do once we step out of that comfort zone. Next slide, please, Sripriya. Yes, and then the intended target of palliative care. Target seems like we are hunting or something, but that's not what I mean. But when we say adult palliative care, most of the times our focus is adult. But yes, we are looking at the relatives and children, and we are trying to somehow involve them in their decisions. But when we say pediatric palliative care, the very definition says child and family, because you cannot imagine a child without a family. The mother is there, the grandparents are there, the uncles, aunts, neighbors, best friends, siblings, all of them are like a huge piece of the child, which you cannot separate. And the family is a very active subject and object of our practice. So whatever you want to do, you have to do it together with the family. There is no point, I think, alienating some members of the family or taking a different aspect of it. So always remember, pediatric palliative care is a very holistic unit, and you can never help a child without helping the family as a whole. Next slide, please. And then what is the lens we use when we see children, right? Like some of you said, we should treat them like normal children. Good, that's a good attempt, but the family itself is facing a lot of distress because culturally, I think all of us are from India, right? So for all of us, there is this mental thing, background thinking that my child should be the one who is cremating me. I shouldn't be cremating my child. right? That itself is like a huge spiritual and emotional distress for the family. So just imagine when a mother has a baby. So let it be a child with Edwards syndrome, Down syndrome. I mean, not all Down syndrome are palliative care, but think about it, anencephaly baby or a child with serious congenital anomalies. Every mother gets pregnant thinking she wants a healthy baby. And here comes a baby who is not healthy, and we are telling them incompatible with life, not going to live, and not going to be normal and things like that. And the child might not live for long. So what would that mean for the family? So put yourself in those shoes where you're bringing something home thinking, or you're choosing something thinking it is going to be good, and it gets ruined. Right? So it is a lot of emotional distress, and for them to come to terms with it itself a huge challenge. Sometimes you say, I don't mean you, but healthcare professionals, we use words like unwanted baby. But when you actually discuss with them, you find out it's not an unwanted baby. These are just scared parents. They're scared to touch the baby. They're scared to handle the baby. And just, you will listen to all these things once you start asking questions. Next slide, please. Yes. And then I was talking about how family is an integral part of pediatric palliative care. So one part of it is, okay, here I just want to say, when you say cancer, in my experience, I've worked in a cancer hospital for 1.5 years. Then I went ahead and started pediatric palliative care in a non-cancer hospital, right? And I was doing both the things. Some days I felt medically and to plan goals of care, it was easier for me to work in a cancer hospital. I'm not saying the suffering is less, but it is a very clear-cut line sometimes. The treatment is working, the treatment is not working. And then the families have time to make peace with it. But imagine a cerebral palsy child. The families are told the child might gain some milestones if you stimulate them. And the child doesn't gain milestones. The child doesn't become normal. And the family is questioning, did I not do my job properly? Is that why my child is not improving? And then they keep getting these repeated infections. And every infection, the child looks like he's going to die, right? And as a palliative care physician, I have to go and tell them, okay, this episode looks very bad. The child might die. But then the child improves. And then the family is like, aha, I told you my child is not going to die. And the child is going to have another bad episode. And I again have to go and tell the same family that this time the child looks bad. And the mom is like, you told that last time. It's not going to happen. My child is going to live. And it might be this episode or the 5th episode after this, the child dies. Right? So it is very complicated discussion with the family, wherein which you're telling they're bad, but you're also somehow communicating that you're on their side and you don't want the child to die, right? So it is a balance between that. And then also because these children have, this term is called medical complexity. They have many needs. And when you come to a high income country, such as where I am right now, Kuwait is a high income country and they have like 2 ventilators, right? One ventilator the child is on at home, and they have a spare ventilator just in case the battery, there is a battery problem. So they have home ventilators, they have infusion pumps, they have all these things going on for them. And this is a totally different topic, right? Health inequities and inequalities. But coming back to the topic, especially in high income settings, because I took this from a Western paper, they do mention about palliative care using a lot of aids and instruments and devices to make their life a little better. And families have to have training to deal with it. Recently, we had a mother whose baby's tracheostomy came out and she reinserted it and went to the emergency room. I cannot imagine someone doing it in a setting where we cannot do all that, right? Like unless they get training at a hospice. So having families to deal with that. And then these families also have, as I said, a lot of psychological burden, and we have to support them. Next slide, please. And in all this, we do have to remember in adult palliative care, if our adult chooses, this is what I want, it happens. In pediatrics, if they choose, this is what I want, it cannot happen unless the parents agree, because legally we are bound to take consent from the parents. There is assent and there is consent, but the family's role is still to provide informed consent. And then a lot of times the location of care, whenever we give them choice, children choose what they want, but families are equally involved in that. And then a lot of the times families want the children to go home. So the houses need to be adapted. Again, this is a bit of high income setting issue, not a low income because they cannot do that. But here what I have seen is they have a ramp to the house so that they can take the wheelchair. Especially Duchenne muscular dystrophy in pediatrics, they get quite heavy because of steroid use, and over a period of time they lose the function of their muscles. So they have these things attached to the ceiling and hoist, and they put belts to their child and lift them. You must have seen that in that Hrithik Roshan and Aishwarya Rai movie, where he is a paraplegic, and to give him a bath, she is so frail and she cannot lift him, and she uses that which is attached to the ceiling. So these could be some part of it where parents have to spend extra money and things like that. Even middle income families will have to do. Next slide, please. And then we call something respite. I'm sure you came across this word when you were discussing palliative care. So respite admissions to hospices can be for two reasons. One is just to give a break to the family. Sometimes the parents can be so overwhelmed and they don't get a break from 24/7 care of their children, and the hospices can take over the children. Again, it depends on each country. In India, what I have seen is the family stays there. In Hyderabad, what we did was small breaks. They weren't that parents can leave them in the hospice and go out. It would be that they would admit, but we would give them a break. Like they can go to a movie with their kids, have a dinner and come back to hospice. And till that point, when the family is away, we will take care of the child. So that would be somewhere 5 to 6 hours. Right? Whereas in the West, what I have seen is they can book hospice, they leave the children completely, and they're legally protected to take care of the children. Right? And here in this country where I'm practicing right now, it is not allowed. The parents have to be with the child, but the parents can be inpatient, and family has a different room and where they can relax and do things. So respite is a chance to take a break, where they get break from the child, because a lot of times we think we have to do 24/7 care of affected children, but it is not humanly possible, right? And in countries like UK, these children are considered to be at high risk if the parents are getting burnt out. Because when you're angry, when you're tired, when you lack sleep, and when you don't have time enough to take bath also, you are at risk of hurting your own child, is what they believe. So things like that, it's very important. And then the other part of it is when there is a lot of technology involved, or caring through NG tube, police catheter and things like that, family might need more training. Next slide. And in all this, one other thing we do have to remember is Dr. Hari Prasad, who is here. Earlier, he was in an ICU setting and he was providing palliative care in ICU setting. So it can be done. And even here, we work with ICUs, and we try to, even when I was in Hyderabad, we were working both with neonatal and pediatric ICU, and we were supporting the parents and also the children in ICUs. And here, a few things to remember about ICUs is that, one, parents are always the caregivers, but when the children go to ICUs, parents suddenly lose that role, because some of the ICUs have very strict rules that parents have to visit only for 1 hour. They can't be with their children and things like that. So that itself becomes very important, and that's why we have to bring them together in making decisions for the child. You cannot say, I'm the intensivist and I will make all the decisions, and you as the family has to follow them, right? And then when we say the child is not going to survive this episode, parents look at it with a different lens and they try to take the child home. And this we have seen even in the Indian context. They want to take their children home if this is the end of it, especially if it's a life-limiting illness, which they have been handling for a long time. I don't mean this in the acute context, right? Pneumonia, end of life, No, this is not what I mean. I mean something that has been there for a long time. Then families make efforts to take their child home. And the other important thing we do have to remember is we know these children during ICU admissions for 15 days, 1 month, or 1 week. But families have been with this child for years and they have been handling all their needs. So sometimes our assessment is moderate, but the family's assessment when they see the child might be more accurate, right? Because each child is special and parents sometimes can give better information. So just remember this if you ever get invited to ICUs, adult or pediatric, just to ensure that the family is involved and how lost they must be not being with their family member at that time. Next slide, please. Yes, and the other thing we do in pediatric palliative care, and this is all the more important, I think, in a country like India, in our settings, is coordinating with schools, especially with children who have special needs. And what do I mean by this? We have had children who were cured of cancer, but weren't being allowed into the schools, right? Because they do not have their hair yet, or they have these marks on their body, or post-radiation, they have become dark on one side of their body and they are normal on the other side. A lot of body image issues they have, or post-amputation, things like that. So just remembering that you as a healthcare professional going to a school sometimes and just having a chat with the principal and the teachers would make a lot of difference for the school and the child, right? And there is bullying in schools that happen, which they might not voice out, but that is the other thing we do have to remember. So coordinating with school in itself, and what we have seen is the community. A lot of times family don't even tell their neighbor that someone in their family has cancer because they're scared that it would be considered communicable, right? Like this must have been discussed in adult. So this is the same thing in pediatric, and it hurts the child more because just go back to your adolescent age group and think about how we wanted to connect with each other. We all wanted friends. We didn't care so much about our parents. We wanted to spend more time with friends, talk to them, share things with them. So suddenly there is the loss of all that, right? So just remember when you're speaking to families to think about what the children, the affected and the siblings are going through in schools. And then the whole part where we are facilitating their social and scholastic activities. This could be as simple as giving children something to read, something to study, and having, groups that they can work together in, talk together in, and support groups and stuff like that. Next slide, please. Yes, and in adult, most of the time what you see is they get diagnosed and they stay in adult for a very long time. But if you remember, I mentioned syndrome babies, premature babies, and cerebral palsy kids. So if you think about cerebral palsy, the definition itself is it's a static disease. So if you're diagnosed, if a child is diagnosed with cerebral palsy at 2 years of age, and nothing severe happens to this child, like life-threatening happens to this child can live up to 30, 40 years of age, right? So what happens when this child crosses 18 years? And we do talk about transitional services. It's not just CP, Duchenne muscular dystrophy. More and more children are living into their third decade of, I would say, they become young adults. Cystic fibrosis, earlier they would all die during their second decade, but now they're marrying and having kids. Not everyone, but some of them, right? So most of the times the transitional services get involved in during 16 years of age, especially pediatric palliative care physicians. They become alert when they become 16, and most of the time they try and transition when they are 18. In Hyderabad, we had a little problem because we were taking in patients till 18 years, but the cancer young adults we kept in the program, whereas non-cancer we tried and transitioned. But again, depending upon the strength of the program, I think of adult, because a lot of times adult palliative care is cancer-based, and a lot of pediatric patients are non-cancer. So if adult is not used to dealing with this, sometimes pediatric palliative care has to keep covering. But this is something that is very important because in pediatric, they might go through many, many stages in their life. We will discuss more about this. Next slide, please. Yes, and staff involved, we did speak about interdisciplinary teams, but when you come to the staff involved in pediatric palliative care, it is quite different. We have some people called play therapists. These are certified people who play in a formal way for a therapeutic result, right? Like it's a part of treatment, a part of venting out. And then we have someone called child life specialists. Again, child life specialists are somebody, it doesn't just have to be pediatric palliative care. Hospitals in itself hire them to help them to go through traumatic procedures like lumbar puncture, bone marrow aspiration, and some kids are scared to stay in the MRI machine. If you underwent MRI for 30 minutes, and if you're claustrophobic, even as an adult, it is a horrible experience, right? So imagine a child going through that. So child life specialists try and make it easy. They're trained in those things. It's a very American concept, child life specialist. I haven't met anybody in India who has done it. I have some child life specialists here. So, but even then we do have a shortage. And then music and art therapists. I have met an art therapist once, but we have a music therapist here. They make a lot of difference. They let the children express through instruments, singing, and we have a teenage girl who is into love songs now, and the music therapist was sharing that with us, right? So we were just thinking, oh, we forget so much about sexuality in children, right? Like especially when you turn 13, 14, love songs are so special and all that. And as adults, we forgot about it. And now she's singing, and this girl has so much attitude. It's funny to hear that she has turned a romantic. So it's very interesting to see all those updates from other team members. And then also there are pet therapy, distraction techniques, and all these things that we sometimes use in pediatrics. So yeah, we get to work with a bunch of different specialities, and it is very interesting what they all bring to the team. But again, I just want to say a lot of times, none of what you see was available to me in Hyderabad. Right? They're very hard to get by. We don't get to see them at all in our setting, especially if we are run by NGOs where our money is very limited, right? So it's okay learning a bit of this, bit of that, and doing it ourselves. We used to do our own play therapy, informal play therapy, right? So we do have to learn. I see what is distraction technique. Distraction technique is something like asking them to count number of bulbs in the room. When you're doing a procedure, you tell them you're doing the procedure, but you tell, can you count the number of bulbs? Can you count the number of butterflies on this page? And they are distracted, and you do that procedure, like removal of cannula or removal of something, right? And showing their favorite cartoon. Yes, I had a child who always wanted to listen to Telugu Jesus songs, like Telugu Christian songs. And then I had a child who liked Doraemon. I had a child who liked Dora. So a lot of times we use these distraction techniques, but always remember, I did ascitic taps with distraction techniques, right? Without local anesthesia, because for them, a poke is a poke. So I had to balance. If it is not a bloody tap or a thick fluid, even a tiny needle would be enough in a child. So one poke, that would be my ascitic tap poke, right? So these children, I would tell them what I'm doing. And then I would say, would you like to see something on my phone? And I would give them the phone. And that would be a distraction technique. I don't like phones, but I used to use them. And then in pet therapy, you can read, I think, more about it online. But if you see more about it, it is known that some specially trained dogs and animals are very aware of feelings, and they tend to be very supportive when people are distressed. And people who are into nature, they distract themselves when there are pets around. And there are some studies which say that people with pets live longer. So I'm not sure about how much they actually help. But from what I have seen, it makes a lot of difference for people who are into it. And I already told you what child life specialist is. It's a very American created post, and these specialists make it easier for the child to transition from one thing to the other. Right. So I was just telling, we have an Edwards syndrome, a 3-month-old child, and her siblings were coming to the hospital, and mother doesn't want the siblings to get attached to the child. So I was just telling to the child life specialist, can you help these child to play in the playroom and bring them for 1 minute the first day? And then, wow, someone is a pet therapist. Someone hire her. Jagriti's daughter is a pet therapist. Your daughter is in demand. Yeah. Just going back, I was just telling the child life specialist, can we bring this child for 1 minute to see her little sibling and go back? And the next visit, can we make it 3 or 4 minutes? So it is not too much for the child that we are overwhelming with the sick sibling, but then we are slowly desensitizing the child to look at their sick sibling and make peace with that. Right? Next slide, please. I'm very aware of the time. I have 9 more minutes. And there are a lot of psychological and physiological differences. As I said, medical complexity is one part of it. Again, it depends whether they are from a low income setting or a high income setting. This was my major distress when I was in Hyderabad, because I was working in a government hospital. And a lot of times I was having my own ethical dilemmas about how eligible they were for palliative care. Would they be more comfortable, or would their life be much better if they had money and access to more investigations? And then I come to this other end of the spectrum, where they revive a dead child and put them through all the machines, and the child is just lying there for the next 10 years. So like you can see like the whole spectrum, but all said and done, pediatric palliative care, there is a lot of medical complexity, and one child could be having like 10 symptoms at the same time. And treating them would become very, very important based on how distressful they are for the child. And then in pediatrics, as I said, they are going through different ages. So imagine your child or yourself, or if you don't have children, just imagine a niece or a nephew, right? When they were born, they were just lying there in that bed. But once they start walking, imagine how things changed in the house. And then once they start becoming 5 years old, 10 years old, the questions they were asking you were very different, right? And once they become 15 years old, the way they were behaving has changed. So imagine if a child who is affected during neonatal age, and you see them as a palliative care physician, and this child lives up to 20 years of their age. How different this child would be. If you treat the child as if the first time you have met them during their neonatal age when they're 10 years, it wouldn't work. So the way they progress through their age becomes important, and the vital signs, it changes, right? Like in pediatrics, newborn, respiratory rate less than 60 is normal. Whereas if it is 60 when we are an adult, it's completely abnormal. So things like that. The heart rate is also quite high. It's 120, 140, 160 when you are a newborn, right? But when you are in pediatric age group, it changes. And the other important thing that we have to remember is vaccination history. So in adults, a lot of times we don't ask about vaccinations. I think the one common thing we might ask is herpes zoster and exposure to chickenpox and things like that, especially in immunocompromised. But beyond that, in pediatrics, always remember, no matter what the condition, ask about vaccination history. A lot of times they might have a bad episode when they have to get vaccinations, and they never go to get those vaccinations, and they are not protected from simple diseases that the rest of children are protected. And then drugs. A lot of times you look at what we have to use, and it is always written, not advised in pediatrics. Haloperidol, not advised in pediatrics, right? Amitriptyline, not advised in less than 12 years of age. But we still use amitriptyline. So that is one challenge in pediatric palliative care. We do not have a lot of evidence. A lot of times we draw our experience from adult palliative care and use it. But again, it's a huge challenge to do studies on children. One, the consent problem of it, the vulnerability problem of it, and the numbers itself you have seen they're so low. It's difficult to get them done. And then what I mean here, evolving understanding, I would say in the next slide. Next slide, please. Oh, sorry. I think I went for physiological differences first. Again, I have just put it here just to say that children are not mini adults. A lot of times they maintain their blood pressure for a very long time and land up in shock quickly. And then they are able to maintain their blood pressure because they can constrict their blood vessels and maintain their blood pressure. And also they have less blood volume. And they can get dehydrated very quickly, unlike us. And that could be the other problem. In newborns, we always say cover them, because they can lose their body heat and they can go into hypothermia. Next slide, please. And this is what I meant by evolving of understanding, is how do they think about death as they go through different ages. And this is important not just in pediatric palliative care, but if you get a 30-year-old breast cancer, 40, like stage 4 woman with 2 children, and it is important for you to understand based on the ages of the children, what they understand by what is going to happen to their mother. Next slide, please. So infants, that is less than 1 year, they do not have a concept of death. So even when they see someone dead, they don't understand. But what affects them is not having a routine. So when this person was there, they would do certain things at certain times. And when that is suddenly taken away, that is what the child feels, the insecurity of it, not the death in itself. And again, we talk about hugging, rocking to soothe them. Next slide, please. 2 to 4 years, they think death is reversible. And they have this magical thinking about death. And so they say things like, they went to God, they're going to come back. And when will they come back? They keep asking this question. And why is this important? Sometimes this child dies of a mother and the older sibling keeps asking, when will the child come back? When will the child come back? The child is not asking to hurt the mother, but because their age is 3 years old, they're thinking it is reversible. So they do not get that concrete thinking at this point. Next slide. And then between 4 to 8 years, slowly the concept of permanency in death develops, but they still have magical thinking. So I have had children who said the day before they came to the cancer hospital, the older sibling and the affected sibling had a fight about the TV remote. And this sibling said, I wish you were never born. And the next day, he got sick and came to the hospital. So the older sibling, who is 7 years old, was thinking, because I wish that, now my brother is sick. Right? So they tend to blame themselves for the bad things that is happening. Next slide, please. 8 to 12 years, they understand that death is permanent. Sometimes they might be even morbidly interested, right? Now I have a 7-year Duchenne muscular dystrophy child who is morbidly interested in death. And he's like, I want to kill them. I have a nightmare. Lion killed me. It's all kill, die, die going on. I don't know if it's the age or it's the PUBG. I don't know. But, there are a lot of death conversation here that they become morbidly interested in death. Next slide, please. The next is the teenage, where they have a mature understanding of death and they can speak in abstract about what has happened, how they feel, and things like that. Next slide, please. And I just want to say this is not a difference. I think if you are going to talk to children, always remember, talk to the child, don't just talk to the parents. Always maintain eye level, the same eye level. And when the child is speaking to you, always be listening, active listening. Use simple words the child will understand, because children tend to literally take your words. So anything you say, they will think, oh, this is what has happened. So be careful in what you're saying to them and be open to their questions and answers. And if you don't know anything, always just say, okay, I'll find out and come back to you. Do not lie to a child. If a child is dying and asks you, am I dying? Don't say, no, you are not. Right? Always go back with, oh, that is a very tough question. Why are you asking? Just go back to that. Don't lie. Don't make promises you cannot keep. And the last point says important conversations are best carried out with the parent present. But also, next slide, please. Remember, sometimes not having a parent helps them to open up, because the second point I have written, children protect their parents. It's called mutual pretense. Children know it, but they don't express because their mom is going to cry, their dad is going to cry. They cannot see their grandmother crying. So they're trying to protect them. Next slide, please. And always remember, pediatrics is a vulnerable population. They are at risk of not being heard. And when asked, where would you like to be? It is always home. No child says, I want to be. No, I'm wrong. I had one child who wanted to be in the hospice. He was scared to go home because every time he went home, he had a bad episode of pain and breathlessness. So there was one child who chose the hospital, but 99% of the children choose home. So try and find out about it. Grief and bereavement is one more thing. It is more complex sometimes, as I said, because this is not something that is expected naturally. This is not a natural life cycle for a child to die early. So these are always complex. Next slide. The other dilemmas we face would definitely be ethical issues and also decision making. A lot of times the child would want something, but the parents might want another thing, and we end up listening to the parent, and it is not always easy for us. So how do we be that bridge between the parent and the child to help? For example, a child might say no to a nasogastric tube at end of life, but the parent might be insisting, I want a nasogastric tube for my child. So it becomes, again, our responsibility, using all the communication skills that we learned, to be that bridge between the parent and the child, to make this last few days, last few weeks as less conflicting to each other as possible. We have had families, like the dying child and the mother were fighting about the treatment, right? And it is so distressful for both of them. And he's already in pain, and he thinks his mother is not on his side. She knows he's dying, and she's fighting with him. So it makes it more complicated. Next slide, please. Yes, at the end of it, think of pediatric palliative care as an entire family. And also, sometimes we don't even have a definitive diagnosis of what happened. Like, we have a child whose two other siblings have passed away, and they have been everywhere in the world. They still don't have a diagnosis. Whether it is metabolic, genetic, they don't know. They have done every test known in the world, right? And it is a progressive muscular weakness. The child cognition is perfectly normal. She already lost two of her older siblings, I think three of the older siblings, and now she is dying slowly, but we don't know what is happening. So sometimes there is no definitive diagnosis. And this is with all the resources. In India, a lot of times we don't even have a diagnosis, but we are providing palliative care because of the physical condition of the child. And then again, pediatric palliative care, just like adult, we give over multiple settings. And always remember, siblings, they are suffering silently. And in adult palliative care, whenever you walk into a house, whenever you walk into an OPD and see a child, always make sure to speak to them for a minute, half minute, whatever your time allows. Just let them feel, be seen, right, that they exist. And then in pediatrics, a lot of time, these patients are with us for a very long time. The child I was telling you about, progressive neurological problem, she's with us since her 2 years of age, and now she's 13 years. And she's with us for 11 years now. So they are with us for a very long time, which doesn't happen so many times in adult. So with that, I end my slides. Thank you, Shri Priya, for sharing. Good that I shared with you as a backup. And over to you, Dr. Singh.
Thank you, Spandana. And now we know that there are a lot of difference between adult and the pediatric palliative care, and the importance of conveying the information according to their age. And it is also important to know that how the children gains the knowledge of death and life. So when we talk to them regarding their loved one, maybe mother or father, we should capture the information according to the age. So there are many things which we need to understand from this talk. And we will move on to Dr. Hari Prasad's presentation now. Hari Prasad sir, it's over to you.
Okay. So am I audible?
Yes, we are.
Okay. So a very good evening to all of you. And again, really happy to see Dr. Sunil, Spandana, and all other dear friends who are very much interested in palliative care, especially pediatric palliative care. And also, I am really thankful to Palliative India because I learned the basics of palliative care from Palliative India. And actually, I thank Rajav sir, Dr. Sunil, and all the other members of Palliative India for helping me in doing at least some amount of palliative care for children. Okay, so I think we had as usual, we had an excellent session from Spandana, and today I'll be just discussing with some of the neurological condition or neuro palliative care, and I think it will be very good if you take time to free in, right? Because as we have got another 40-45 minutes, and please feel free to interact in between the session. Okay, so I shall share the screen. So hope the screen is visible.
Yes.
Okay, so just before proceeding, how many pediatricians are there, or how many of you have got experience dealing with children needing palliative care? Anyone? Have you come across children needing support, needing palliative care? Okay, so anyway, we'll proceed. So these are our learning objectives. First, I'll be sharing a few clinical scenarios, and I'll be discussing how I managed in a hospital setting and without any major support from a palliative care team of as my own. Second, the most important conditions needing pediatric palliative care, important symptoms of these children, other issues, and finally, what is our role as a palliative care physician whenever we come across children with needing palliative care. Okay. So this is actually, this child is at present admitted in our ICU at Rayala Medical College. You can see he's a 10-year-old boy who is completely moribund. And you know, he has got almost all the complications you can anticipate. And as you know, this is a classical condition of quadriplegic cerebral palsy, and he is a quadriplegic. He has got seizures, he has got spasticity, contracture of all the limbs, of all the joints, and all the issues of aspirations and feeding issues, and kyphoscoliosis, and all the secondary complications of kyphoscoliosis. So this is one case scenario, and this is another kid who is an extremely intelligent girl, but was diagnosed as a congenital myopathy. And you know the complications of myopathy. Child has got all the muscles are very weak, and secondly to that, her cuff is weak. Her is prone to have recurrent aspirations, leading to chest infections, and practically child was in and out of the hospital for the first 2 years of life. I came across this twins when Rayala Medical College was converted as a COVID hospital. Actually, you can see the second of team who was diagnosed having a global developmental delay with intractable seizures. And I saw them, this is at around 6 to 7 months. And they had multiple hospitalizations. They were getting frequently hospitalized in a very famous hospital in Kochi. And in spite of the spasticity and all other complications, my child was subjected to daily physiotherapy, and the treating doctor told them that no wonder drug will be coming in the market very soon, and that is going to cure the child. And the parents were living with that hope. And the baby, again around 6 to 7 months, with a no definite diagnosis. Again, the diagnosis is global development with intractable seizures, and the story is just like the earlier baby, that is Jerome. And he was also practically in the hospital for nearly 7 months. He's almost an adolescent boy, has a definite diagnosis, that's a mucopolysaccharidosis, to be exact, Sanfilippo disease. He has got, he's intellectually disabled, and the most worrying problem is his aggressive behavior. Nobody can manage him. He has very aggressive, significant district attitude, and has got a very severe temper tantrums, which is very, very, very difficult to manage. Spandana was mentioning about the Edward syndrome. This kid, 1 year old now, was diagnosed with as Edward syndrome and having intractable seizures, and child has become oxygen dependent now. So I have mentioned a spectrum of diseases. So what does all this indicate? The spectrum of children needing palliative care. And I think Spandana already has shown one graph, which is a global. And actually, this is again from our own textbook, that is a textbook of Paediatrics Nelson, which shows that, as Spandana already said, only about 5 to 6% of children needing malignancy comes from cancer, whereas the remaining 90 to 95% of children needing needing palliative care are suffering from non-malignant. And even though here it is said that only 2.3% come from neurological, if you look at the content anomaly, it forms 25%, neonatal conditions 15%, and meningitis per se 12%. That means if you add all these content anomalies, neonatal conditions, all of them will be suffering from mainly neurological. So if you add all these, I'm sure it will come to around 60 to 65%. And what is the burden of pediatric palliative care? Actually, there is no correct estimate. The International Children's Palliative Care Network has estimated that about 21 million children need palliative care all over the globe. And they have also estimated that about 6 million children need palliative care in India. But actually speaking, we don't have a true statistics, and we don't have a true data. So I just looked at, this is from Toronto Medical College, where I was working before getting transferred to Ernakulam. And this shows that about more than 60% of children needing palliative care are suffering from neurological conditions. And among them, at least most of them are having cerebral palsy, that about 3/4 of them are having cerebral palsy. So if you, I think, I'm sure, even in your practice in future, if you come across, if you take a statistics, I'm sure that about 2/3 of children needing palliative care will be suffering from one or other neurological condition. So how to decide who are the children needing palliative care? I think this is the ACT guideline. So it definitely gives the 4 categories of children needing palliative care. So now let us look at one by one. The first category is the disease is life-threatening. Here, the curative treatment is available, but sometimes it may fail. And the classical example is tuberculosis, meningitis, developing sequelae. We know that the TB meningitis is classified into 1, 2, 3, and 3. And once the child goes into stage 3, that is a sequelae, and they are going to have a permanent disability. And so this is one classical condition. And so on. So post-encephalitis sequelae, like Japanese encephalitis, also comes under this. So there is a diagnosis, and we know that the disease is life-threatening. Curative treatment is available, but there is a significant chance that it may fail. And this is the illness trajectory. We have a diagnosis, then there is some amount of remission, and finally they will have relapse. Again, we treat the symptom, and finally death occurs. But by the time the child dies, it goes for years. That means the suffering is significantly prolonged. This is category 2. So these are all the muscular dystrophies. Spandana was mentioning about the Duchenne muscular dystrophy. So I showed a child with a myopathy. So all dystrophies, all myopathies comes under this category. Here also we know that there is no permanent treatment, but we have got treatment with which the child is able to live for a prolonged period of life, but finally the child will suffer. So this is the illness trajectory. We make a diagnosis, the child is stable for some period of time, but then again there will be remission and remitting and relapsing, and finally death occurs again, probably after a few years. Category 3, the classical example is trisomy 18, which I showed you. So here we know that the condition is progressive and the treatment is palliative from the diagnosis itself, or the almost majority of the metabolic conditions, neurodegenerative conditions, and some syndromes like the Edwards syndrome, the Patau syndrome, all this comes under this category. So here we have a diagnosis, but we have a steady downline course, and finally the child will die. Usually it takes months, but sometimes it may take years also. And this is the fourth category, that is the most common. So here there is severe disability. Child is prone to have almost all the complications, and we expect that to occur prematurely, but again that will take many years. And the classical example is quadriplegic cerebral palsy, or hypoxic injury to the brain, road traffic accident going for permanent damage of the brain, and severe brain malformations. So here this is the illness trajectory. We have a diagnosis. Again, there's a waxing and waning course. Death occurs, but again at the end of many years. So just before moving to the symptom complex, one word about cerebral palsy. All of us know that the most common condition needing palliative care in children in neural conditions is cerebral palsy. But please, whenever when you see a child with a diagnosis of cerebral palsy, please ask for the following history. If there is there any history of similar illness in other siblings or the family members? Is there a consanguinity, or is there a clustering of similar conditions in the family tree? If you get such a positive history, please remember that there are a lot of metabolic conditions where it can mimic as a cerebral palsy. So we label them as cerebral palsy mimic rather than cerebral palsy, because cerebral palsy is a ruling out diagnosis. So it's a metabolic, it may be a metabolic condition, and we are living in the 20th century where genetic studies are available. And if you make a diagnosis, sometimes even cure is possible. So please remember this point. Whenever you would come across a child with labeled as cerebral palsy, please see that all his other cerebral palsy mimics are practically ruled out. And any person making a diagnosis of palsy, please grade him based on this. That is the gross motor function classification system. It's very simple, and I think we'll be dealing with if you have got time, and if you don't know him in detail about that, probably we'll deal with at the end of the session. So please remember that gross motor function classification system is the system by which we classify children with the cerebral palsy based on the function and level. Okay, so now let us look at the symptom complex. You name a symptom, they have it. So we'll just go over the symptoms one by one. The first is the agitation or the neuroirritability. So what is agitation or neuroirritability? We know that many of the children goes on crying unnecessarily, inconsolably. We don't know what is the basic reason for their crying, and that is agitation or neuroirritability. So they present with a complex symptoms of signs. It is very distressing to the patient, to the child per se, and all the family members, and probably sometimes pain may be the most predominant factor causing agitation. So any child with agitation, you please, if you have got time, please apply this scale. That is the non-communicating NCCPCR. That is the scale for non-communicating children to assess whether they have a pain. We assess the children under these 7 headings: the vocal, the social, the facial, the activity, body, limbs, physiological, eating and sleeping. And if you get a score of 7 or more, that indicates pain. So neuroirritability is uncontrollable crying in such a child. And please, you may take over 20 to 25 minutes to apply the scale. If you have got time, please try to apply the scale and find out whether the child has got severe pain. And what are the other measures to be done? Yes, correct the correctable. So you can, from this, it shows that anything that is irritating the child from head to foot child can present as agitation or irritability. It may be poor sleep. It may be an ulcer in the body. It may be a dislocation of the hip. it may be excessive salivation, it may be underlying pneumonia, it may be constipation, it may be underlying UTA. So have a detailed exam of the child, find out is there any correctable causes, and if there is any correctable causes, please correct that. And other supportive measures like maintain if there is fever, control the fever, appropriate positioning, that is the best position of comfort, etc. And the drug of choice for agitation after correcting all these correctable and after going for supportive measures is gabapentin. And other drugs used is one is amitriptyline and second is pedicloral, which is a chloral hydrate, which is available in India as pedicloral. So these are the first drug of choice is gabapentin, and then we can support the amitriptyline. But many a time, again, this pedicloral is not at all costly, and you can try chloral hydrate for agitation. Second is spasticity and contractures. We know that almost all these children will develop spasticity. What is spasticity? That is the child developing increased tone, they're leading on to hypertonia and leading on to even contractures if the spasm is not getting controlled. So, and ideally you should again just like the GM-CSF, there is a another classification that is called the Ashworth classification of spasticity. So here the difference between managing spasticity of a normal child and that of a child with neurological illness, chronic neurological illness is here we had to find out the functional level of rehabilitation. For example, if for a child having spasticity, if he was a normal child before that, we will try to have an absolutely normal tone at the end of the treatment. But if the child is chronically ill, we had to find out the functional level of rehabilitation because the child will be more functional at some level of spasticity. For example, if the child has got some amount of spasticity and we can make the child sit in a commode, that is his most comfortable posture. So whenever we manage spasticity in a child with a chronic neurological illness, first find out his activities of daily living, our goal in maintaining his activities of daily living, and find out his functional level of rehabilitation, and find out the appropriate tone needed for that posture to be maintained. So this should be our approach. And what are the, how do you manage? Yes, again, the non-pharmacological measures. One is the physiotherapy, exercises, massage, and bracing. And the drugs, diazepam, baclofen, and tizanidine. And for local spasticity, we can go for injection botulinum toxin. And please remember that if a child has got severe spasticity, please do not start physiotherapy as soon as you make a diagnosis, because giving physiotherapy for a child who is having spasticity is extremely painful. That will add on to his agitation. So you bring down the level of spasticity to some extent by using diazepam. You just give 0.2 to 0.3 milligram per kg for the first 10 to 15 days. We need to give every day. And if not improving, you can give a small dose of baclofen also. And after the spasticity is under control, you start physiotherapy. And sometimes surgical measures like a tenotomy or a rhizotomy may help in improving the spasticity. So another topic is the seizures. We know that most of these children will throw a seizure, and they will be on multiple anticonvulsant drugs. So as a palliative care physician, our duty is to titrate the dose of all these drugs. And please you should be aware of the common dose of all these drugs, because in pediatrics, you always titrate the dose of drugs based on the milligram per kg and with a maximum dose that is usually the adult dose. So continue the adult the anti-epileptic drugs and titrate based on the milligram per kg. And please remember to teach the caregiver to use midazolam nasal spray. It just costs about 250 to 300 rupees. And if the child throws a seizure, the caregiver can control the seizure at home itself by using this midazolam nasal spray. And please remember that fever will precipitate, or fever may precipitate seizure in all these children. So tell the mother to give paracetamol at a dose of 15 milligram per kg per dose, and clobazam 0.5 milligram per with a maximum dose of 10 milligram at the onset of fever. So If the child is in seizure and developing a fever, you continue the anti-epileptic drugs, give paracetamol, do the tepid sponging, and also give him clobazam at least for the first 3 to 4 days. And sometimes the parents may fail to administer through the mouth, and so please remember to stock paracetamol and diazepam, that is a rectal preparation at home also, because at all times it may help. So these are my advice to manage seizure. Continue anti-epileptic drugs, modafinil NSSP to be stored, paracetamol and clobazam and the onset of fever, and please stop rectal paracetamol and diazepam. But dystonia? Dystonia is not a rare symptom in childhood neurological illness. What is dystonia? That is a simultaneous contraction of the agonist and the antagonist. So please remember that pain, fever, stress, dehydration, and some drugs can cause dystonia. So if the child has got fever, control it. The child has got pain, manage it. And if the child is dehydrated, hydration is very important. And the drugs used is levodopa, trihexyphenidyl, and tetrabenazine. So these are the 3 drugs commonly used for managing dystonia. What other causes? Breathlessness is very common. We know the child has got breathlessness because of multiple reasons, maybe due to underlying pneumonia, maybe due to restrictive lung disease, maybe due to underlying reactive airway disease. In all these conditions, they will manifest as cough, tachypnea with increased work of breathing, and any child with a chronic respiratory distress, they will have polycythemia, and the child will develop complications of polycythemia. And I think we'll be discussing it later. So how to manage breathlessness? Yes, I think all of you know the headings, correctly correctable. Find out any focus of infection, or that is a pneumonia, treat it. The child has got any evidence of reactive airway disease, manage it. And other than that, sometimes they may need oxygen, continuous oxygen therapy, and we can provide home oxygen concentrator or CPAP machine at home, and always facilitate airway clearance by measures like postural drainage, manual vibration, increasing or suctioning of the oropharyngeal area, and as well as abdominal binders, because abdominal binders will facilitate cough. And other measures to bring down breathlessness. Sometimes the child will have pseudobulbar palsy leading on to increased secretions, and that itself get aspirated. So you can go for glycopyrrolate. And practically speaking, if even glycopyrrolate is not needed, you can just give a homatropin drop. The ophthalmology use a homatropin eye drop to dilate the eyes for the fundus examination. You can just apply this homatropin drops, a few drops, to dry up the secretion. That is practically enough. And to thin out the secretions, we can nebulize a child with 3% saline and N-acetylcysteine. So thinning of secretions and the measures by which you can bring down the amount of aspiration. And Dr. Spandana already mentioned regarding the vaccination. And please remember to vaccinate the child with the yearly influenza, because, and ideally, if possible, the parents can afford, we should vaccinate all the family members also, because sometimes even if the child may be normal, the parents or the siblings will carry the infection from outside. So you vaccinate the child, and if possible, at least vaccinate the siblings also. Vaccinate the child with influenza and pneumococcal vaccine. And we know that in paediatric care setting, morphine needs the drug for breathlessness. I'm not going into the details. So you start put him on a small dose of morphine, and any hand writing morphine should prescribe similar laxative diet, as well as antipropantic agent, metoclopramide. And to bring down the anxiety, we can also use benzodiazepine depending upon the condition. And another very important issue that we come across in children with chronic neurological illness is a gastroesophageal reflux disease. So I think this is probably the most important reason why child develops aspiration pneumonia. So what are the measures to be done? One is, please avoid exposure to smoke as much as possible. Smoke will precipitate GERD. Maintain him at least during feeding and after some time after feeding. Maintain him in the upright posture for feeding. And if he is fed on very thin feeds, you thicken the feeds And it has been proved that acidic foods like tomatoes, chocolates, mint, juices, and caffeinated and carbonated foods will increase the reflux. So avoid all these acidic foods. And then we have got a tendency to elevate the head per se. So please do not use pillows for elevation. Instead, you raise the head end of the bed because that will bring down the chance of reflux. And any child who is prone to have reflux should be put on a proton pump inhibitor and a domperidone PPA like pantoprazole in the morning, 1 mg per kg, and domperidone 0.2 to 0.3 mg per kg per dose half an hour before each food. And if the child has got severe GERD again, we can try baclofen. So these are the measures to bring down the GERD. Other measures, generally we see all these children who are so cachexy. Why? We know that if the child is taking less than 50% of the calorie needed, what is needed for the child, that will lead on to catabolism, because we need 50% of the 50% recommended intake to meet the basic metabolic rate. So any person who is not taking 50% of the recommended calorie intake will develop catabolism, and that is why our children are taking cachexy. So please ensure at least 80 to 100 calories per kg per day and 1 to 2 grams of protein per kg per day. So this can be divided into 6 to 8 feeds, and you can plan the diet. And this child is again prone to develop almost all the macro and the micronutrients because the child is not at all exposed to sunlight. So vitamin D deficiency is very common. So please ensure him adequate sunlight exposure. And if there is vitamin D deficiency, supplement it. And please ensure vitamin A prophylaxis program also, because we know that in India, all children from 9 months to 5 years of age is given vitamin A prophylaxis. Nine doses is given at 6 months interval. So please ensure that. And also ensure or the intake of all the micronutrients that is in the form of green leafy vegetables and seasonal fruit, green, yellow, orange fruits. And immunization, we already said, all vaccines as per the immunization should be given, and at least the influenza vaccine should be given per year. Probably the most important single cause as a source of infection in all these children is dental caries. So please ensure dental hygiene as much as possible, and also ensure adequate annual checkup. And we must know that any child with a developmental delay, improvement of the vision and hearing will facilitate his development. So to have children to have a normal development should have normal vision and hearing. So evaluate their vision and hearing, and if anything can be corrected, please correct it, because that will improve the quality of life for the child significantly. Another issue is a very feeding problem. I think these are the issues. I think we already mentioned that spasticity, pseudobulbar palsy, and the pseudobulbar palsy is very predominant. And if possible, I think the best advice is to go for a gastrostomy, that is pediatric endoscopic gastrostomy, which is a simple procedure. If possible, that can be done, because that will help the mother to feed the child. It will also prevent aspiration to a great extent. If that is not possible, for right tube aspiration, GRD already mentioned, and aspiration, I think we have already mentioned all this. So feeding problem is probably another important area to be addressed. Excess secretion, I think already mentioned, that is oral glycopyrrolate and chromatropin. And another important issue is the constipation. And so please ensure mobility as much as possible, ensure adequate hydration, ensure adequate fiber in the diet, and also please give a stimulant laxative in the form of Dulcolax or polyethylene glycol, and also stool softeners, because by all these measures, ensuring adequate hydration, fiber in the diet, stool softeners, and stimulant laxative, we can bring down the constipation to a great extent. And please remember that unaddressed constipation will precipitate UTI, because rectum press upon the neck of the bladder. So any child who is bedridden having constipation is bound to have urinary tract infection. And another issue is the bladder symptoms. We know that these children have varying level of damage in the brain. So depending upon the damage of the brain and the spinal cord, they have different types of bladder. It can be an automatic bladder, like as of a newborn. And sometimes the child, the capacity bladder will be very less. That is called a spastic bladder, where there will be very frequent urination. Sometimes the tone of the bladder is completely lost. That is called the atonic bladder, where there will be overflowing. So ideally speaking, we have to study the type of bladder, and depending upon the condition, we may have to go for a clean independent catheterization. We may have to give alpha blockers, etc. So, if possible, try to understand the type of bladder and you try to manage the symptom. So, having discussed the symptom complex, what are the other issues? I think Dr. Spandana already discussed in elaborate regarding other issues. So, just we'll run through this. The psychological issues is very, very, very important. So there are a lot of psychological issues for the child, caregiver, and the sibling. The children per se, as I showed, that children with myopathy, it was completely depressed. They per se will have suicidal thoughts, and they will always have a fear of death. Caregiver, yes, they are also depressed, they're anxious, and they have got a very great insecure feeling and worry about the future. So again, we did a small study in the caregivers, and it was revealed that they didn't have, almost all of them had a severe personal distress. They did not go for any social activities because they were socially embarrassed. And even though the parents were with the child, they didn't have adequate information, and they don't have a leisure time at all. So they had to be with the child 24/7, 365, and they didn't have any time for extra time for care. And as Pandit already said, unlike cancer, these children can become bad at any moment. They can also improve dramatically. So unpredictable illness is there. And actually, it is this time where they will always go for divine intervention as well as immune breakthroughs. So probably the most important single question they will come and ask you is, what will happen to my child if I am not there? So I think this is a very, very great question. We have to find an answer for that. So what will happen to my child if I am not there? This is a very worrying question for them. So probably the most important persons who are forgotten in this complex issue is the siblings. So many a time they cannot go for the school because the parents cannot send them home because the sibling will be at a hospital. They have got poor self-esteem, and both in the school and in the society, they may be socially isolated, and there may be bullying problems at school, and they too have adjustment problems. So just like the caregivers, we also did a small study on the siblings, and it was revealed that no one was there for their active listening. They were not even hugged or kissed. They're not even rewarded, and the mother failed to give quality time with the sibling. And even though they wanted to understand about the illness of the sibling, no one was discussing about the child to the siblings. And at some point of time, they prayed to God that they wished they had belonged to, or they wished that they should belong to another family where there is not any child. So this shows the amount of psychological stress in the siblings. Financial issues is significantly great, especially in Indian scenario. We know that so even though a lot of government support is there, still all the families with the chronic neural illness are suffering a lot. Many a time the breadwinner cannot go for work. The child has been taken to a hospital many a time. There is very frequent hospitalizations. Sometimes both the parents has to be with the child, and there's a lot of change in the family dynamics. And we just looked at the out-of-pocket expenditure of these families, and it was revealed that about 80% of the income of the family was spent for the child. When such a child is taken to a nearby hospital, what will they do? Sometimes they will have only OP, so they will refer immediately. Sometimes it is a single man doctor, the doctor may not be available there. And even if sometimes the doctor sees there, the parents feel the child was not given appropriate care. And many of the time, they will, as soon as they see the child is chronically ill and the child has been treated in a tertiary care center, even asking for the symptoms of the child are present, the child will be referred. So most of the time, even for trivial symptoms, these children will be referred to the nearest tertiary care center. And for transport also, most of them will depend on private transport because we don't have adequate public transport whenever they need. So to sum up, when there's a neurologically child, the child with a significant disability, a lot of symptom complex they are having, they've got other comorbid factors, their lifespan is limited, at the same time, it was for years, they are completely dependent. That means the parents or the caregivers has to be with them throughout the day and night, throughout the year. A lot of psychological issues is there for the child, for the siblings and the family. They're significantly financially compromised and they are socially isolated. When such a child is taken to IFA hospital, what is happening? Yes, we have got a lot of IFA hospitals, but all the hospitals provide a disease-oriented treatment. So here, everybody will focus on the disease of the child or illness of the child. There is significant patient overload. So most of the time, doctors spend the same amount of time for a child with an upper respiratory infection as well as for a child with a chronic illness. We have got all the specialties, the neurology, cardiology, nephrology, all specialties are there, but all of them are working at their own areas, at their own timings. So if they want to have a concentration, they may have to take the child every other day to the hospital. And even if the child is admitted, one fine morning, we just discharge the child and we fail miserably to continue the treatment at home. And almost all the hospitals fail miserably to support them psychologically, socially, or financially. So here comes the role of palliative physician. So what is their need? They need a clinician who will address their complexity. So this is our role. So as a palliative physician or as a palliative doctor, we should be equipped to meet their complex needs. We should be able to provide them high quality primary care. We should advise regarding the immunization. We should help them to have a continuity of care after getting discharged from the hospital. And we should also focus on the preventive care, like the dental care is prevention. And we should also act as a link between the family and the healthcare team and the center. We should also help them to have a shared decision. And we should also help them to have access to urgent care. And Dr. Spandana already said we should act as a link between pediatrician and adult physician, because many of the time they go into adolescence. And in India, even though even Indian Academy of Pediatrics has accepted 18 years as upper age of pediatrics, in almost all the hospitals, at least in the government setup, we are admitting only up to 12 years because after 12 years they become teens, and we cannot admit an adolescent boy and adolescent girl in the same one. So just because of the lack of facilities, at least in India, at least in government hospitals, we admit children only up to 12 years, and just we cannot admit children above 12 years. We also do not see children above 12 years. So transition into adult care is very, very, very important whenever we deal with the children with chronic neurological illness. So what is our duty? To help them to meet their needs through proper communication, be giving meaningful hopes. And the answer, as you know, is palliative care, which should start at diagnosis. So having discussed this, now let us come back. You know, this is the first time who has, at present, he is admitted in a very, very moribund state. So you can see, as we discussed, that he's having almost all the comers is having. So what did we do? Yes, we started him on the appropriate drugs for to control the seizures, fast sitting contraction, and he also got agitation. So we put him on gabapentin. Also, we started him on other non-formal measures like rocking movements, positioning, massaging, vibration. And probably the most important other issue was in kyphoscoliosis. We know that when the child had kyphoscoliosis, child develops restrictive lung disease that will lead on to respiratory failure and pulmonary hypertension. So we put him on a chest physiotherapy, postal drainage, thinning of secretions, oropharyngeal suction, bracing. Also, we gave him all the vaccination which was not given, and also yearly influenza vaccine. And we also have them took by an oxygen concentrator. And at present, we are trying to maintain him on oxygen concentrator and planning to discharge him. And we also advised a nutrition rehabilitation, and you can see we had a right stroke in him. But even though we tried to put a peg, we could not because the surgeon was reluctant. So at present, we are planning to send him on a right tube feeding with all other supportive measures. This child, Dia, you told him, he's a very good intelligent IQ, but at the same time, he had a very severe weakness because of congenital myopathy. And so we went in a detailed history of them. So this was the only child of their of an intercaste marriage couple. You know, a Hindu marrying a Muslim was after effect, or both the families abandoned the couple. So because of the child's repeat aspiration, child was in the hospital practically in the first 2 years of life. They had taken the child to all the hospitals in Kerala to make a diagnosis, but they had done a lot of investigations, including 3 muscle biopsies, but there was no final diagnosis, and they were on the verge of a family suicide because they was totally helpless. There was no family members, and they could not go for work. So what did we do? So we put him on all the supportive measures, proper feeding, management of GER, management of chronic lung disease in the form of inhalers, yearly influenza, treatment of GERD, bring down the spasticity, starting physiotherapy or supportives. And finally, with the repeated counseling, we could manage to get an MRI done. So, and luckily, we could confirm the diagnosis with an MRI brain, with a blood test. We could confirm the type of myopathy, which came as a Merosine negative congenital muscular dystrophy. Actually, this Merosine negative congenital muscular dystrophy runs in families. So again, that was another dilemma. So we told them that we will be with them throughout the next pregnancy. They were coupled, they were motivated to become pregnant again. The mother had the confidence in us. So mother became pregnant. We did a chorionic villus sampling at the appropriate time, and the result came as negative, and she delivered a normal baby, which is around 4 years now. And the child has not been hospitalized for the past. So I think even with the limited facilities, we could revolutionize the life of this family. And Pratil, the child is going to school. This baby, yes, we made a final diagnosis of Burst syndrome, and by the time the child was, I told the child, I saw this child during the COVID time. The child was very moribund. I thought the child is not going to survive. So I discussed regarding the fatality of the condition, the incurable illness of the condition. Also told them that no wonder drug is going to come in the future, in the near future, to save this child. So with the repeated counseling, with the daily repeated counseling, they understood that the child is not going to survive long. So we took a shared decision to prevent or not to discontinue all the futile treatment. So we discontinued all the futile treatment. The child did not have any IV cannula. So all the drugs he was on, we changed was to subcutaneous route, and child was sedated with the midazolam. Child had respiratory distress for weeks. We put him on morphine, and they were elected to put a rice soup. So to maintain his hydration, we put him on a DNS subcutaneous, which is called hypodermolysis. But to our surprise, the child recovered and it is nearly 2 years now. And you can see the child, even at the end of 2 years, child, she has grown up a lot, even though, and she's a normal, he is the child with Swiss syndrome, even though he throws a seizure once, and then the parents are able to manage with the Madasal nasal spray. And so even at the end of 2 years, the child is living, and the family is very happy that they got quality 2 years for the kid. And we also entered into an advanced care plan, and we have also written a written document regarding withdrawal from ventilator if the child becomes moribund, and to continue with end of life care if such a situation arrives. And this baby, we confirmed the diagnosis by genetic testing, that is, which was a mitochondrial disease, and the child was a very moribund state, and we proceeded with the end of life care. And we have also told them to plan the next pregnancy and to go for an antenatal diagnosis when time comes. And we are supporting through bereavement measures. And this boy, it is very, very difficult. So I put him, I put the scenario of him because even when we discuss neural conditions, we totally forget the neuropsychiatric disorders, because as pediatricians and as palliative care doctors, we'll be coming across a lot of children who have got a lot of psychiatric issues, and the most important thing is aggression, distress, attitude, and temper tantrum, and intellectual disability. And if you refer them to psychiatrists, we know that the number of psychiatrists per million of population is very, very, very rare. We don't have adequate number of psychiatrists to manage even adult psychiatric patients. So whenever possible, I think if possible, to have a word with the psychiatrist, and if possible, please try to put him on some drugs. I think that I just put 2 drugs here. One is methylphenidate and second is risperidone. So these are very, very two relatively safe drugs to bring down the aggression and destructive behavior of children, especially neurological illness. So please, if possible, have a psychiatric consultation, and even if they fail, please either put him on risperidone. If you start with risperidone, start with 0.25 milligram per day, and you slowly titrate, and the maximum dose is 1.5 to 2 milligram, and for adolescents 2 to 3 milligram. And methylphenidate, the dose is usually 1 milligram per kg per day, and they will have a lot of sleep disturbances. And many of the time, we can provide them a comfortable sleep with the trichlorophos, that is a pedichloride or the chloral hydrate, or we can put him on melatonin. So we have put him on risperidone, and his aggression has come down. And this baby, I told me, said Edwards syndrome. We gave all the measures, and we know, you know, that I'm working in a tertiary care center where we don't have any palliative care support. So I put him on all the drugs for seizures, feeding issues, aspiration, etc. But I didn't have any funding to have an oxygen concentrator. So I just challenged our house surgeons and students, and we must. I was really astonished because within just 72 hours they came out with an oxygen concentrator. They raised 42,000 rupees, and this happened last week. And you can see myself here, and you can see our principal and our HOD and the students handing over the oxygen concentrator to the parents of the family. So I think there's a lot of compassion in the young generation, and I think we can play miracles if we have got the will. And as I told you earlier, this child is also having polycythemia because of the chronic respiratory insufficiency. And any child on polycythemia, please ensure adequate hydration, because dehydration can precipitate storms. And please also put him on prophylactic iron therapy for 2 milligram per kg. Also put him on folic acid, because this way, because otherwise child will develop other complications of polycythemia. And if possible, if facilities are available, at least do an echo once in a lifetime. And if the child has got significant pulmonary hypertension, put him on a small dose of nifedipine or sildenafil, because this will bring down the symptoms of pulmonary hypertension to a great extent. So this is the oxygen concentrate being given to the parents. So to sum up, pediatric palliative care, how does it help in children? yes, there is better understanding of the illness. The family, we can make the family accept the illness with dignity. We can please remember for giving immunizations, for giving dental care. We can teach them methods of rehabilitation. We can also provide them high quality social support, including home care and emergency conditions. And the most important, single important point is we can discontinue the futile treatment options. So the families also will gain a lot. We can bring down the rates of hospitalization. We can revamp the family support system. We can improve the care of the siblings. And we can also bring down the financial burden of the family. So with advanced medical care, we know that a lot of children are going to suffer from neural conditions and they need palliative care. And whenever possible, multidisciplinary palliative care centers like Palliative India should be established in different areas in the country. And whenever possible, as palliative care doctors, we should try to provide continuum of care, and we should also ensure community services and policies. We know that India is a vast country, a great country with a lot of differences between the rich and the poor, the west and the east, the south and the north. So I think as palliative care doctor, we'll be working at different conditions. We may be a single man doctor. We may be working as a part of team. We may be working in a peripheral center. We may be working at a tertiary care center. So depending upon the facilities, the take-home message is that I think we can provide whatever is possible, and even with our little help, we can play wonders in their life. So I think pediatric palliative care is just in the neonatal stage, even in the 20th century in India. I think if all of us join hands together, I'm assured that we can take pediatric palliative care forward so that we can bring down miracles, we can bring down rainbows in the life of these children and their families. Thank you. So thank you, Dr. Palliative India, for inviting me, and over to Dr. Sunil.
Thank you, Prasad, for that wonderful session. And one important thing that I listened was when it comes to pediatric, any pediatric care, the families spend most of the income on the, and as per the study which was conducted in SAT, we understood that 80% of the income is going for child's care. So we know that many of the patients or family, they will not be able to afford the cost of hospitalization, and many of the families will be going below the poverty line. And this is true not only in case of pediatrics, but also true in case of adult patients. So I think we will now open the session for discussion. I can see there is two by Sunita. Please enlighten us where all can adult palliative care trained doctors supporting pediatric palliative care. So what is the role of adult palliative care physicians in supporting pediatric palliative care? And the next is, please suggest us some go-to referral centers in India where we can refer such kids who need palliative care. So, Spandana?
Yeah, I'm just thinking about the second question. The first is a bit easier to answer. I don't think I have it ready on my computer. Let me just check it. But we have a pyramid which says primary, secondary, and tertiary on the top, right? So the people who still do not receive any kind of training would come under basic, like suppose a doctor who's trained a bit in during MBBS or during their post-graduation, and they want to practice general pediatrics or regular medicine, but occasionally see palliative care patients can come under the one on the lowest block, who do not do it a lot, but still do it. I'm just trying to find that pyramid. It's easier to explain showing a picture. But the second level is the secondary, where there is some specialty, where suppose you are all going to be adult palliative care physicians as you go forward, and you're going to do a bit of pediatric palliative care on the side, you fall into that category. And the last is the pediatricians who are practicing pediatric palliative care. I found it, but I'm not sure if my computer will let me share it. In case it doesn't let me share it, I will still share it with Shri Priya and ask her to share it with you. Let me just see. Are you able to see this?
Yes.
Yeah, yeah.
Yeah.
Yes, yes.
So this is the one. The one below is the universal, and then the core, and the final one is the specialist palliative care. Right. So I would say adult palliative care physicians who want to deliver pediatric palliative care would come here. Right. So definitely there is a huge role, and you all can contribute for it. And the second part of it is, as I said, referring them to centers sometimes can be very, very difficult in their condition to travel. So we do have a few helplines out there, Sat Sat helpline, and even Pallium India. They're trying to help children all over India. I have had, I have made some requests to Pallium India, and using their contacts, they try to help few children. So always try and find out what are the resources. IAPC website has places where, palliative care is provided. You could contact them and ask if they see children, and it is a lot of work. It is a lot of coordination, but it would always be helpful if we could refer them somewhere closer to where they're living, rather than sending to this 1 or 2 centers, which might be very far away. Having said that, I think Pallium India, they do quite a bit of pediatric palliative care in the community. And the other places I can think of is, if anyone is in Mumbai, BJ Wadia Hospital has pediatric palliative care. Hyderabad MNJ Cancer Hospital and Nilofer Children's Hospital, they have pediatric palliative care, and we do have a adult and pediatric hospice of 10 beds there in Hyderabad. And then Delhi, anyone close to Delhi, there is Can Kids, but I'm not sure how full it is. I haven't spoken to them in recent times, but I believe they do quite a bit of pediatric palliative care. So there are little pockets where they do pediatric palliative care, but as Dr. Sunil said, it is always challenging to have a program up and running in our situation. Over to you, Dr. Sunil.
Thank you. Any other questions?
Good evening, sir.
Yeah.
Sir, recently we went for a home care, and there the child, he's having cerebral palsy, and he is on Pediasure. This is the only thing which he takes. The mother and the family, everybody is upset. He's now around 7 years. Still, he's taking Pediasure. He's not taking any homemade food or anything. So what can be done in this situation? They tried putting Riles tube, but the child was constantly pulling it out. So what do you think can be done in this situation?
Is this child feeding orally?
Yes, ma'am, but he takes only Pediasure, nothing else.
Okay. Hari Prasad, sir, I see you have unmuted. Please go ahead.
Okay, I think so. The children are very fond of Pediasure. That is because it is very tasty. But at the same time, the problem is that it is really costly. That's the most important, because I think one bottle of about 200 grams of cost about nearly 400 or 500 rupees. They have increased their cost
sir.
recently. So that's the most important reason. And if you look at Pediasure, we say it is an isodense formula. What do you mean by isodense formula? That means 1 gram will give you 1 calorie. That is called an isodense formula. So I think the best way for this is to slowly replace with isodense milk. So I think we should be able to, we know that 100 ml of milk gives 70 calories. Okay. So if you take 100 ml of milk and if you add 1 teaspoon of sugar, that becomes 9 because 1 teaspoon of sugar gives you 20 calories. Okay. So you take 100 ml of milk, add 1 teaspoon of sugar and plus 1 ml of oil and 1 ml of coconut oil. So 1 ml of coconut oil will give you 9 calories. So this is an isodense formula that is equivalent to Pediasure. Okay. So I think generally what we do is, and many children, we slowly bring down the amount of Pediasure and increase the amount of milk. Okay. And most of the children will love the taste of milk, or will add some other additives that will, so that the child, it becomes tasty. Okay. So if you slowly replace Pediasure with isodense milk, this is another very good replacement, and we can bring down the cost from 500 to 50 rupees. So that is one thing. And second is you can make them prepare local home available feeds. For example, what's that? Groundnut. Groundnut is really rich in protein. Okay. And it is said that 1 groundnut will give you 2 calorie and 0.5 gram of protein. So take some groundnut. You can mix it in milk. You can add a small amount of sugar or jaggery, because jaggery is rich in iron. So jaggery will give you iron. This milk will give you protein, and groundnut will also give you protein. So this is also an isodense formula. So I think these are 2 methods, and another method is giving ragi. So ragi is also really rich in calorie. 1 gram gives you 4 calorie, and it is also rich in iron, many zinc, and also folic acid. So actually ragi is rich in many micronutrients. So you can just like giving groundnut, you can make ragi in a semi-solid form. And if the child, since the child is able to swallow, most of the children will ragi, because we know that in India, at least in southern part of India, like Kerala and all, we use ragi as the first complementary feed at 6 months. So I don't know whether it is that practice in North India and all, but ragi is a very good other alternative option for Pediasure. So my main message is replace Pediasure with other energy dense food. And these energy dense foods are one is as I told you, it is ragi. We can make isodense milk. Then we can give a potato. Potato also 100 grams will give of potato will give 100 calorie. And another is roasted banana. So banana also is a high risk food. And if the child is a little bit older, we can give egg. So we can mix egg with milk, and we can give it. So these are some other options. So similarly, so depending upon your local area, depending upon their availability, and depending upon the cheap foods available, you can advise them to prepare their own diet, and you can add jaggery or sugar, and you can add 1 or 2 ml of oil, because oil will improve the taste and also will improve the calorie. So I think this is my advice to replace Pediasure. Spandana, anything to add?
No, sir, I really like how you gave multiple options. And always when we are advising anything, it's important to consider the family also, right? Like the financial status, and also how long you want to give them Pediasure. And at 7 years, if Pediasure is the only thing the child is taking, the family must be running through a complete bottle every 2 days. So I cannot even imagine how the family is putting up with that cost. So that itself is a huge burden for the family and distress to the family. So
Thank you, sir. Thank you so much for that beautiful piece of advice. Because this family, the child is constantly on the mother's lap. He's not at all willing to get down from there. He's constantly crying. And recently, he has started this aggressive behavior also. So,
What's the
as
age of the
again,
child?
7 years, sir.
Oh, 7 years. Okay. So I
Uh,
think, as I told you, you find out here, what is his weight, approximate weight.
I think the
He's so
mother
minor
said that
as I showed you in the photo.
yes, he is.
Okay, so that means the child is not getting at least 50% calories. That is why he is becoming so malnourished. Okay, so
Okay.
if he is able to swallow, I think we can try all the local foods that is available. Okay, you can we can do one thing. You can even make the rice. You can mix the rice with the jaggery and a little bit of oil, and it may turn out to be tasty for the child. Okay, so I think you can just um, try some alternative methods which is locally available, which is cheap, and which is energy dense also.
Okay, sir.
Yeah.
And also in your presentation, I saw if none of this thing is working, we can try PEG. So is it really
It is
possible
advisable.
in?
Okay, so the problem is that in private hospital, at least in Kerala, in private hospital, PEG costs about 50 to 60,000 rupees. Again, the finance is the most important. But if you can afford a surgeon to put in a PEG, it is very easy. But I don't know whether any pediatric surgeons or any other gastro surgeons are doing it. If it is possible, it will be well and good. But
Okay.
please ensure that they are giving some food through the mouth also, because food is not only for calorie, but it is for only for taste also. So even if you put the PEG, you give at least some amount through the, at least for his for tasting, give through the mouth also.
Okay, sir. Thank you. Thank you so much. Thank you, ma'am.
Okay. So, Spandana, I think Sangeeta, you might have seen the comments from Spandana also regarding the pain and the problems.
If the child is crying continuously, we do have to think about pain. And there are different scales about it. I'm sure when you get your pediatric palliative care information sheet for your fellowship, you would find all the scales in it. And we call them non-verbal children who are not able to express. And we call it FLACR scale, FLACCR. And also the other scale Dr. Hari Prasad showed, that is also for non-communicating children. So you sit with the child and you look at it. These are not subjective scales where the child is telling I'm in pain, but instead you look at the child and you score it. And there are such scales, and please assess that. And also, Dr. Hari Prasad has said what could be the multiple triggers for pain, right? It could be something as simple as when the child sleeps, the child doesn't close eyes, and the child could have a corneal abrasion or a inturned eyelid, like eyelash, which is irritating the eye. It could be a UTI because the child is not emptying the bladder fully. Or it could be a UTI because the child has recurrent constipation. It could be because these children, if not effectively mobilizing, can have osteoporosis as they go forward. They could have a hip fracture, hip dislocation, or any other fracture elsewhere. So you will need to do a general examination and see if there is any particular reason this child is in pain. Spasticity in itself could be causing pain, right? So sometimes using paracetamol 6-hourly would make a lot of difference for these children. And then aggressive behavior, we have seen children who have little cognition with aggressive behavior, especially males. When they become 13, 14 years, their behavior is considered inappropriate with women because they are developing sexuality because their body is developing, but their brain doesn't have those inhibitions. So it becomes a huge problem where the sibling sister has said, why is my brother alive? Let him die. And mother is asking, can I send him off somewhere and never have to see him, and things like that. So please involve a psychiatrist early when you see aggressive behavior in CP children.
Okay, so I think there would be a lot more to discuss, especially with two faculties who are experienced in this. But we have to wind up the session. It's 9 now. So thank you, Spandana and Hari Prasad sir, for joining us and taking us through various aspects of pediatric palliative care. It is always challenging, and whenever you hear about pediatric palliative care, you will think that no, this is not enough. I have to hear more. So that's the feeling that you will have. But you will also get a module on pediatric palliative care. So once again, thank you, Spandana and Hariprasad sir. And thank you everybody for your active participation. It's our pleasure.
Thank you, Dr. Spandana. Thank you, Dr. Hariprasad. I believe that the comments itself say it has been a very insightful session. Thank you so much. And thank you everyone for joining. Before winding up, just a gentle reminder that tomorrow we will not be having session, but we'll be having a session day after tomorrow. I'll be posting the details in the group. So did we meet again day after tomorrow with another interesting topic and yet another eminent faculty? This is Sripriya along with Dr. Spandana and Dr. Hariprasad with Dr. Sunil Kumar signing off from Palliative India's presentation. See you in the next session. Till then, everyone take care, keep spreading happiness. Bye-bye.
Okay. Thank you.